Still have a really good program for everybody, so if we can take your seats. So we are continuing, and again, we'd love it if plenty of seats in the front. So, and if you're watching online, by the way, I want to thank GCI for live streaming this. We're starting to see we have a lot of Alaskans who couldn't make it here physically who are watching this online. One of the things that as Alaskans, I know that we're all proud of, I certainly am somebody who brags about it a lot, is our veteran population. And I know we have some veterans here. If you're a veteran, can you raise your hand or stand up? How about a round of applause for our vets? So, you know, it's a stat we know. I certainly like to brag about it. More veterans per capita than any state in the country, in Alaska. Additionally, which is really impressive and amazing and a special form of patriotism, Alaska Natives, like Native Americans, serve at higher rates in the military than any other ethnic group in the country, which is amazing. So we thought it was very appropriate for to have the top-level officials from the Veterans Administration, particularly the Veterans Health Administration, who are focused on these issues because, like a lot of communities, our veterans are suffering from this crisis. And it gives me great pleasure and honor, again, to have both Dr. Jennifer Lee, who is the Deputy Undersecretary for the VA's Health Administration for Policy and Services, and Dr. Karen Drexler, who is also a senior official at the Veterans Health Administration, both of whom are very, very focused on this issue, both of whom came all the way from Washington, D.C. For this summit and are going to spend some time with our VA officials after this meeting, but I'm very, very honored for them to both come up to the podium, join us, and then if there's time, we're going to have some Q&A for them too. But please welcome Dr. Jennifer Lee and Dr. Karen Drexler.
Thank you so much, Senator Sullivan, for convening the summit, for your leadership in addressing head-on this really terrible public health crisis and epidemic that is affecting, as you heard, not only the state of Alaska, but every state in the nation, and of course our veteran population. It is such a pleasure to be here with you. We're really delighted to be invited and to be a part of the discussion. This is an issue we take very, very seriously, and we wanted to share a little bit about what we're doing to both prevent the problem and also to address it head on. I also want to say a special thank you to Senator Murkowski for her leadership in so many health issues and also for being such a great advocate for veterans from your state and across the nation. So as you heard, I'm a physician, so is Dr. Drexler. I'm actually an emergency physician. Dr. Drexler is an addiction psychiatrist, so we understand this problem personally and professionally. And I can tell you from my experience in the ER, having taken care of many patients who are suffering from this disease of addiction, especially having personally cared for patients who are addicted to opioids and heroin. I trained in Baltimore, and it's a huge problem there, and it's a tough one, but it's one that can be overcome. And we heard that this morning from Kara Teria, Christina, Kim, and Julie, thank you so much for sharing your story and for hammering home that there is hope and there is recovery. I also came to VA in April from state government. So I served as Deputy Secretary of Health in the Commonwealth of Virginia. And there, my office co-chaired our state opioid task force with our Office of Public Safety. And excited to, again, to bring some of that experience to bear my new role at the VA. But again, the issues really transcend all boundaries and all populations. What I wanted to talk about first, and then Dr. Drexler I'll hand it off to her, is actually the topic that the physician at the end of the last session raised, and that is the issue of prevention and preventing this problem. And I think it's valuable to take a step back and say, how did we get into this situation? And to think about that, and as we go forward, not only addressing the addiction through treatment, looking at the enforcement issues, but also saying we need to prevent the problem going forward. And I think that as a physician, I can tell you that most physicians are well-meaning and want to treat patients who are in pain, but we don't always have the right tools or training or education in how to do that most effectively. And we recognized that at the VA a number of years ago and tried to address that head on. So again, going back to, let me see here. I don't know, how do I advance this? Yeah. Okay. Oh, okay. Well, maybe the battery died. But what our first slide, sure. Or you could advance the slide. What the first slides I had up were to talk about the problem of chronic pain. So chronic pain is a very common problem across the nation, and it's actually even more prevalent in the veteran population. So the Institute of Medicine released a report a few years ago that said that over 100 million Americans suffer from chronic pain. And the veteran population, it's even higher than that. And the problems of pain that they suffer with are actually more complex as well, because they're related to multiple traumas from combat, from musculoskeletal and from nerve injury, complicated often by traumatic brain injury or other psychological issues. And all these issues, when you put them together, cause an increased risk for substance use disorder and addiction. Oh, here we go. So as you can see, the rate of chronic pain, the prevalence of chronic pain in the veteran population is about double that of the general American population, even as high as that is. And it's especially high in the older population of veterans. This is, thank you. This is important, okay. This is also important for us to think about pain, because pain is a risk factor for, it impacts a veteran's quality of life, but it also is a risk factor for suicide. And we're very committed to reducing veteran suicide as well. So what is our goal when it comes to pain management? We really want safe and effective pain management, and we want to provide services that help a veteran to have the best quality of life possible and that help them to be functional. Our goal is to ensure that they're not suffering from pain, and to also ensure at the same time that they're not suffering any adverse effects from the way that we want to address and treat their pain. So we address pain management from multiple different angles, and we can do that because we are a system that has so many comprehensive services. We work together across disciplines to do it in pain management teams. We also have a number of alternative treatments that I'll outline on the next slide. And our goal is really, again, functionality and quality of life. So we have evidence-based treatments for pain using medications. And there are a number of different types of medications that you can use besides opioids to treat pain. But VA also can offer veterans ways to treat their pain that are not medication-related, or in addition to that, as to help complement medication for pain. And those include physical therapy, chiropractic care, exercise-based therapies like recreational therapy or pool therapy, hypnotherapy, meditation, yoga, tai chi, massage. These are all services that we support in the VA. So I wanted to talk a little bit about our VA's opioid safety initiative, because one of the goals, again, as we treat veteran pain, is to use opioids appropriately and make sure that we're not causing any harm or risk in the way that we treat pain. And so in 2013, VA launched a nationwide opioid safety initiative that does a number of things. It helps us track and just have good visibility using data into how much we're prescribing, whether we're prescribing opioids effectively, and leading to any risk at all by prescribing opioids along with other medications too. And we have a lot of data now to share to show that we are truly making headway in our education with providers and how we're prescribing. These are some of the metrics that we use to track our opioid prescribing in the VA and that we've been doing for a few years now. And alongside this, the tracking and the data is really the prevention strategy, and that has a lot to do with education. So we work closely with the Department of Defense to come up with a pain management curriculum and guidelines for how providers really should be prescribing and managing pain. We provide specialized support to our providers for whether it's through pharmacists, whether it's through other specialists that they can consult or call upon to know how to treat complicated patients who have pain as well. And the education is really working. And I'll show you some data in just a second, some graphs here. We also have electronic tools. So we have tools, this first one, this stratification tool for opioid risk mitigation, or STORM as we call it for short, is a predictive analytic tool that helps us to determine which patients might be at more risk for adverse effects if we prescribe them opioids, and that a provider should take caution before initiating therapy. The second is the opioid therapy risk report. And this is a dashboard, again, data that help providers to monitor the safety for patients when they're prescribing longer-term opioids for pain. And again, so now we have a lot of data to share, and we are just thrilled to be able to show that we've made a lot of headway, and we have a long way to go, but still, this is really very encouraging for us to share. So from July 2012 to March 2016, we have shown a reduction in the number of patients receiving opioid prescriptions by over 20%. We've shown a reduction in the patients receiving both opioids and benzodiazepines, which is another strong drug that together puts a patient at more risk. We've shown a reduction in patients who are taking high-dose opioids as well, and I'll show you some graphs here. So this is for all veterans throughout the system receiving an opioid prescription, and you see that we have over a 25% reduction since 2012 that we believe is a result of our educational efforts with our providers and some of the tools that I shared to reduce risk. This is in particular for the Anchorage VA Medical Center, where we've seen a decrease in veterans receiving an opioid prescription. This is the decrease across the system for veterans receiving both an opioid and a benzodiazepine. It's a 47% reduction since 2012 when we started the program. And similarly, in the Anchorage VA, shows the reduction in veterans receiving a opioid prescription for longer than 90 days, for long-term prescription. And this shows appropriate monitoring, so veterans who are on longer-term therapy, are we monitoring using urine drug screens? And that's actually a component of the CARA Act that was recently passed. And this shows as well similar trends at the Anchorage VA. And this also shows a decrease in the veterans receiving high-dose opioids. So I'm going to turn it over to Dr. Drexler now to talk about how we treat those veterans who have substance use disorder. But we're really encouraged by some of the data that we've collected to show that our educational and tracking efforts are working and helping to prevent the problem going forward.
Thank you, Dr. Lee, and I'd like to also add my thanks to Senator Sullivan for the invitation and to all of you for coming and starting the dialogue together. I am excited to share just a small slice of what we are doing in VA to treat veterans with opioid use disorders and other substance use disorders, but I know that we have a ways to go and we can't do it alone, so I really appreciate this opportunity to partner with you. So in the interest of time, I'm going to go through this rather quickly, and I have left out a lot of the information on background. I'll go through it quickly. And our approach really is evidence-based. We partner with the Department of Defense to develop clinical practice guidelines that are based on the scientific evidence of what works in addiction treatment. And then our policies are written based on those guidelines, and having that policy that we expect at every facility, these services would be available. And at each small clinic, other services would be available, really helps to keep each facility on track. And then I can show a little bit about our trends in SUD treatment. Okay, and we've heard from Dr. Wakefield about the prevalence of the problem, that substance use disorders are common, and that they are at least as common among veterans as they are in the general population. In the Alaska healthcare system, it's very similar to the nation as a whole. About 8% of Alaska's veterans have been diagnosed clinically with a substance use disorder of those that receive treatment in our system. And of those with a diagnosis, almost 30% receive specialty SUD treatment. And these are the trends in the diagnosis. I just wanted to keep in perspective that by far the most common substance use disorder among veterans, excluding tobacco, is alcohol use disorder. So the top line you see in red is the trends in alcohol use disorder. Below that is those who have both an alcohol use disorder and another drug use disorder. And then finally, the lowest line, the least, is those who have a drug use disorder only. For those two lines, the next slide breaks it out into the four most common substance use disorders, and that would be, for a long time, it had been cocaine, had been the most common, but as you can see, the other three have been climbing. The second line in green is cannabis use disorder. The fuchsia bright pink is the opioid use disorder, and we've seen that crisis nationwide. And then finally, methamphetamines. I mentioned the VA DoD clinical practice guidelines. These are available online. Any of you can access them. We just recently updated them in 2015 and went from over 160 recommendations, many of which were based on expert opinion, to 36 distilled down recommendations that are based on the evidence. And when I talk about the evidence, what I mean is that in the past, historically, when guidelines started being produced, it was largely based on expert opinions. You would get folks who were experts in the field, put them in a room together and say, what do you think folks should do? Over time, we have added support from research studies. And for this particular guideline, the gold standard, of course, if you have it, is a randomized controlled clinical trial. And for this guideline, it's based almost exclusively on the randomized controlled clinical trials, and then even better, a meta-analysis of multiple clinical trials. And here in one slide is a summary of what we recommend. So let me quickly go through that for you. We know that alcohol use disorders are the most common, and we have good data that universally screening veterans every year for at-risk alcohol use, and if they're drinking above recommended limits, providing a brief intervention makes a tremendous difference. So that's part of our policy as well. We know that because opioid use disorders and other drug use disorders are less common, it may not make sense to screen everyone annually, so we recommend it only in targeted populations, like those that are receiving long-term opioid therapy. We have specific treatments for specific substance use disorders. For alcohol and opioids, we have good evidence that medication-assisted treatment helps, and we're promoting that nationwide. And then we also have specific psychosocial interventions. And I will go through just a few of those, particularly for opioid use disorder. For opioid use disorder, we have lots of evidence, meta-analyses from multiple clinical trials, that medication-assisted treatment, particularly with buprenorphine naloxone, also known by the brand name Suboxone, or methadone through a federally regulated opioid treatment program, save lives, improve the quality of life, and improve overall health care. We also have evidence from one randomized controlled clinical trial that long-acting injectable naltrexone, which blocks opioid receptors, is also effective for treating opioid use disorder. In all of these clinical trials, the patients who received the medication were also receiving some kind of treatment or counseling. And in particular, medical management, which can be done in a primary care setting, as Dr. Wakefield mentioned, HHS is rolling out, has been shown to be effective. And in the opioid treatment programs, contingency management and individual drug counseling have been shown to be effective. So these two approaches are ones in particular that we are promoting nationwide and here in Alaska. In addition to medications and counseling or psychosocial interventions, we promote group mutual help participation, and as our panel discussed this morning, getting involved in a recovery community is absolutely key and helps. So we encourage that. Addressing co-occurring mental health conditions, which has also been mentioned, is an important part of what we do. And being an integrated healthcare system, we're able to do that. And then continuing care. Substance use disorders are chronic illnesses. They do respond to treatment, but like other chronic illnesses, it's important that there be some sort of continuing care and not just brief episodic treatment. And finally, we have specific recommendations around stabilization and withdrawal, or also known as detox, helping folks safely get the drugs and alcohol out of their system in order to start more comprehensive treatment. These recommendations that are evidence-based are based on a foundation of shared decision-making. We feel this is very important, that the patient is the expert on his or her life experience, and they know their own strengths and weaknesses. What the clinician's job, like mine, is to know the full menu of evidence-based options and to provide that information in a way that's easy to understand so that the patient can make informed choices about what is going to be right for that individual. We promote collaboration, or something that we call shared decision-making. And it's also important to periodically check in to reassess how someone is doing and then to modify the treatment plan as appropriate. So for medication-assisted treatment, which is especially important for the opioid use disorder, as we've heard, too many Americans are dying of overdose. Medications like buprenorphine, methadone, and injectable naltrexone can save lives by not only preventing relapse, but if someone slips and relapses, they're much less likely to die of the overdose. So we are promoting that both through our policy, through the informatics tools. Like Dr. Lee mentioned earlier, we have other ways to leverage the big data from our electronic healthcare system to help guide leaders and individual clinicians on who is most likely to benefit from the medication and where they can target their efforts. We also have a national formulary that includes all the evidence-based medications on the formulary, and we're working with provider education. And in Alaska, we are doing, as we are in the nation, about a little less than a third of veterans who are diagnosed anywhere in our system, whether it's the emergency room or primary care, are receiving treatment for their SUD in a specialized program. Among those with alcohol use disorder, about 8% receive medications for their alcohol use disorder nationwide. Alaska does a little bit better. And for opioid use disorder, Alaska does about the same. Nationwide, it's almost a third of veterans are receiving first-line medications. And here's the trend over time in medication-assisted treatment. And then we're also working to promote overdose prevention with naloxone rescue kits. An important part of that is the education about the risk for overdose. We're targeting not only patients with opioid use disorder, but also those who are receiving opioids for long-term for chronic pain. And we have dispensed over 35,000 kits nationwide, and we have over 170 reversals that have been reported. And this just shows the trends over time in that opioid overdose education and naloxone distribution. All right. And in conclusion, as so many other presenters have said, substance use disorders are chronic illnesses. They respond very well to treatment. We are looking forward to the opportunity to partner with you to provide the best treatment we can for Alaska's veterans. Thank you.
You guys want to take a few questions? Okay, great. Okay, well, you know what? I didn't read Dr. Lee or Dr. Drexler's bios to you because they're really long and they're super accomplished, but it does actually drive home a point that these women could be doctors, probably making tons of money anywhere they want in the country with their backgrounds, and they have dedicated their professional careers to serving, you know, our men and women in uniform and the veterans. So we have time for, I think, one question, and I see one right up there.
Hi, I'm back. Thank you for the opportunity. You know, in addition to doing chronic pain work, for over 20 years, I've been seeing patients, veterans, at the request of the VA for specialized nerve and muscle testing. And, you know, through the years, I've been very impressed with the way that the VA providers, primary care providers, did not prescribe a lot of opioids and really did a good job in managing their patients without falling into that trap. My concern is, and I would like your comments on changes that you anticipate with the CHOICE program, and now having veterans going out into the community and getting care from providers who are not so judicious in their prescribing practices. Thank you.
Yeah. Well, I think we are also concerned about that as well. I think as we have, veterans have in our system have always, the majority of veterans in our system actually do have some other options for care, and that will, we anticipate, increase over time. We want to make sure that the care that our veterans receive are really evidence-based, top-notch, quality care with every tool that we can. I think that the issue is, again, education and training of providers, and that's why it's so important that we have forums like this where we have multiple stakeholders from the state, from tribes, from communities, from across the nation come together and say, okay, we need to commit to following the best practices and the guidelines that we know work and that protect veterans and all of our patients. Yes.
If I could add to that, one of the terrific provisions about the CHOICE Act is that the prescribed medications, except for like short-term for urgent needs, come through VA pharmacy so that we are able to track those prescriptions, and our database knows who's a fee basis or a non-VA provider versus the ones who are in-house. And so we will be able to monitor those trends over time.
Well, thank you again, and Dr. Lee, Dr. Drexler. How about another round of applause for them? So, and they have been gracious enough with their time. They're going to be here for lunch. They're going to be here for the breakouts. So if you have additional questions for them, these are literally two of the top experts in the entire VA system here at the summit all day. So please take advantage of that. Thank you very much. So, you know, one of the things that we're trying to do here is we're certainly here to learn. And we have a lot of experts from outside the state coming here to help us on these issues, like Dr. Lee and Dr. Drexler, but we don't have to leave the state to get some of our experts right here. And our next guest, our next speaker, Dr. Joshua Sonkis, is a homegrown expert right here in the last frontier who is going to be talking about an important issue, which is just the science of addiction, what happens literally, physically, or chemically in your brain, why this happens, why this is so gripping. Again, I don't want to spend too much time on his bio because I want him to be able to speak to you, but he's a certified psychiatrist practicing in the Golden Heart City of Fairbanks, undergraduate and graduate degrees right here at UAA. And this is his specialty. So please give a warm welcome to Dr. Sonkis.
Great. Good morning. Thank you, Senator Sullivan, for having me here today, and thank all of you for being here. Well, let's see if I can figure out how the clicker works. That didn't work. See, I learned something in medical school. I know that didn't work. Okay, there we go. So I'm here to talk about the science of opioid addiction. And as you can see from the list here, science means a whole bunch of things. First, it means basic science, drugs and receptors. So we'll talk a little bit about that. It means neuroscience. It means brain structure and function, different parts of the brain and how they communicate with each other. It means the psychology of addiction. It also means what treatments work and what treatments don't work. Okay, that's amenable to investigation by science, so we'll talk a little bit about that. Outcome research, economic research, which interventions are cost-effective on a population basis. I'm not going to cover that today. Mostly I'm going to focus on the first two with some reference to the third. And I'm going to turn the microphone a little bit so I can see you and my slides here. Can you still hear me? Great. So let's start with receptor science. You have exogenous opioids and you have endogenous opioids. Endogenous just means coming from the inside. I think most of you here have probably heard about endorphins. Endorphins make you feel good when you go for a run. And they are an endogenous opioid. There are also enkephalins and dynorphins. They're neurotransmitters. They're ways that cells communicate with each other in the brain. Opioids, endogenous or exogenous, they bind to receptors that only bind to opioids. So keep that in mind. Their effects are that they bind spinal cord receptors to decrease pain. They bind receptors in another part of the brain to decrease norepinephrine, and that will decrease your wakefulness. We'll talk a little bit about that. And they also increase dopamine, and dopamine causes pleasure, and that's what got us into this mess to begin with. Let's move on to neuroscience. Talk about some basic structures in the brain. The prefrontal cortex, that lives right behind your forehead. And that's the part of the brain that makes you who you are. It gives you your personality. It also is the seat of will. It's where you do all of your thinking and your reasoning. And it's where you exercise judgment and plan your decisions and carry them out. And it's also where you restrain yourself. That's where restraint comes from. So it's the center of will. Right below that, also kind of right behind your forehead, is the nucleus accumbens. And that is the seat of pleasure. We'll talk about that. When you feel good because you just ate a tasty meal, or you caught a fish in an Alaskan stream, or you had sex, or you shoot up heroin, that's where the pleasure comes from. Now, down deeper in the brain is the ventral tegmental area, and that's the seat of reward. And basically what that thing does is it tells the nucleus accumbens, the seat of pleasure, when to create those pleasurable feelings. And they all work in a feedback loop. Way down deeper in the brain is the locus ceruleus, and that thing, basically its job is to keep you awake and keep you paying attention. Now, some of you look like you're having a little trouble with that right now. I can tell you, we can actually test the functioning of the reward circuit for all of you, because if you're laughing at my jokes, it means that your reward circuit is functioning correctly. So here's a picture of the reward circuit. The PFC up top there, the nucleus accumbens right below, the ventral tegmental area, and then, again, the locus ceruleus way down deep. What happens here is that the prefrontal cortex says, hey, I just did something awesome. I passed a test, I got a promotion, I did something fun, and it tells the VTA, the ventral tegmental area, it's okay to make me feel good. So then the VTA sends some dopamine back up to the nucleus accumbens, and the nucleus accumbens is like, oh, that feels great. Okay? It's a circuit. The VTA also talks to the locus ceruleus, and it says, you better pay attention because there's a saber-toothed tiger coming in the back door. Okay? That keeps us awake. And the importance here in terms of opiate use is that opioid overdose shuts that thing down. And that's why it stops telling you to breathe, and that's why you can die from an opioid overdose, in very simple terms. So why do people start abusing opioids? Well, we kind of already talked about this. The bottom line is that these opioids, the exogenous opioids, they're much more powerful than what your body produces. They come in, and they take over. They bind to those receptors in the VTA, and then the VTA just opens the floodgates of dopamine, sending these pleasurable signals up to the nucleus accumbens, and your brain is just flooded with pleasure. That's basically what happens. It causes this very, very intense pleasure. You with me so far? So then, why do people keep abusing opioids? And sometimes I read comments in the ADN, and they say things like, well, why would anybody start doing that? And if they did, why would they keep doing it? Well, the reason that they keep doing it is because when you experience super duper intense pleasure, you start to make associations unconsciously, deep in the brain. They're unconscious memories that direct you back to that activity that caused the pleasure. Now, once you've got those memories in place, whether you're aware of it or not, they're going to influence your behavior, okay? So bottom line, people learn that opioids are pleasurable. I know you're all sitting there thinking, well, of course we all know that. We don't need to go to school to learn that opioids are pleasurable. Of course you don't, but you need to think of this kind of learning. This is more like Pavlov's dog than your school teacher. It's not book learning that we're talking about here. So this is one of Pavlov's actual dogs, courtesy of Google. And this dog cannot stop salivating when that light flashes. Okay? You can tell him he's a bad dog. You can put him in his kennel for 10 years. You can put him in therapy groups. You can explain and explain, but this dog can't stop salivating because that's how strong that learning is. The other way to think about this, I haven't really been hacked, okay? The other way to think about this is that opioids, exogenous opioids, really hack your brain. They hack that reward circuit. They come in, they take over, and they divert it from its normal, adaptive, evolutionary purpose, which is to make things that are good for you be pleasurable. And instead, it starts telling you the only thing that's pleasurable is getting your next fix. That's why people keep using. Now, key concept here, tolerance, okay? Some of you probably know what that is. Tolerance is the idea that you need more of a drug, ever more of a drug, to get the same effect. So some heroin users will tell you the first time they shot up was the best time ever, okay? And it was never as good after that. And that's physiologically true, because what happens is that your body adapts. Your brain makes adjustments so that it functions normally when the drug is present and abnormally when it doesn't. A little counterintuitive, but we'll go into a little more detail in a minute. You can think of tolerance like driving with the brakes on. Okay, so pretend you got one foot on the gas and one foot on the brake. And I've driven the Parks Highway a number of times, and I think some people actually do drive like that. If you want to go faster, you push harder on the brake, right? But your better judgment, or excuse me, you push harder on the gas. If you want, I've driven the Parks Highway too many times. So if you want to go faster, you push harder on the gas. But then your better judgment, in control of your left leg, pushes on the brake so that you don't exceed the speed limit, all right? Then you have to push harder on the gas, and then you have to push harder on the brake. And it goes back and forth like this until the pedal is to the metal on both sides, all right? And that is why we have to have ever-increasing doses of a drug. That's not true for all drugs. It's not even just applicable only to street drugs. There are lots of drugs that are not addictive that can give you tolerance. But this is basically the idea of how it works. At a physiological level, what does that look like? Well, one of the main mechanisms for tolerance is receptor downregulation. So I don't have a pointer, but you can see there are 3 cells here. You can think of them as really just one cell. It's the same cell across time. And on the left, there's the cell with the membrane and the nucleus in the middle. And on the outside, there are all these little red things. Those are opiate receptors, okay? You can think of them as mailboxes that accept only a certain kind of mail, all right? They only accept morphine mail, say. And the little orange dots, those are morphine, all right? They're floating around. This particular cell, call it a brain cell, it functions optimally when it only has 2 of those mailboxes full of morphine mail, all right? Now, as you can see in the picture, it's got way more than 2 occupied because there's so much morphine floating around. It's not supposed to be like that. So the cell starts making adjustments. It downregulates the receptors. It takes down the mailboxes, okay? Now, in the middle, it's kind of halfway through downregulating those mailboxes, but it still has too many mailboxes full of mail, so it takes down some more, and this cell only needs to have 2 mailboxes erect on its surface in order to keep 2 mailboxes full at all times. That's an addict's brain functioning normally with drugs present. That's how it works. Now, what would happen if we took away all of those orange morphines? Gas pedals all the way to the floor, and you suddenly take your feet off the brake. The picture kind of gives it away, right? So as soon as the driver takes his foot off the brake or her foot off the brake, that dragster is going to accelerate to 100 miles an hour in just under 1 second, okay? And that, folks, that's what withdrawal looks like. That's what withdrawal is. And this is to illustrate withdrawal, this is an excerpt from the clinical opioid withdrawal scale. It's a scale that physicians use to measure opioid withdrawal, the severity of withdrawal. You can see some of the symptoms there. Next key concept, dependence. This is simple math. Like I said, I went to all those years of undergrad and medical school and residency. I can add tolerance plus withdrawal equal dependence. That's really all there is to it. Okay, that's what drug dependence is. It's tolerance plus withdrawal. Now, the big question is dependence the same as addiction? I gave you the answer. It's not. There might be some folks in the audience who really are confused about that, so let me try to explain the difference here. Think about clonidine. Clonidine is a blood pressure medication, all right? It's kind of a heavy-duty blood pressure medication. Not very many people take it, but some do. And it drives your blood pressure down in such a way that if you ever run out, you forget to renew your prescription, your blood pressure will shoot back up not only to as high as it was when you first were starting to take it. It will overshoot and give you what's called a rebound hypertension. That's withdrawal, okay? If you take an antidepressant, you can also get a withdrawal syndrome if you stop taking it for some antidepressants, but nobody ever built a criminal lifestyle around Prozac, okay? I've had some patients who tried to snort it, but it didn't work out. That's true. Nobody craves blood pressure medication, and I wish they did, because my patients would be a lot healthier if they did. Okay? So if dependence is an addiction, what is then? Well, there are lots of definitions, as you probably know. I'm going to go with one from the federal government, the National Institute on Drug Abuse. And it says addiction is defined as a chronic relapsing brain disease, okay, that is characterized by compulsive drug seeking and use despite adverse consequences. Okay? That's the definition that I'm going to go with here today. I'm going to talk briefly about models of addiction because not everybody's ready to think about addiction as a medical illness. All right? We have a moral model. Okay? You're bad. You have a weak character if you use drugs. We have a criminal model. We're going to put you away in jail if you use drugs. We have a recovery model that really speaks to a personal journey through addiction and sobriety. And then we have social, which involves learning theory and other things. And then we have a medical model, or more particularly a biomedical model. Now, I'm going to really speak to the last two because the rest are not amenable to scientific investigation. And I'm here to talk about science. Scientific evidence increases as you move down this scale. There's two main models of addiction, biomedical models. Okay, the first is the set point. Anybody here who's tried to lose weight is going to understand exactly what that means. Okay, it means your body wants to stay at a certain weight. If you lose a little bit, that's fine, but it's going to creep back up on you. If you gain a little bit, it might creep back down if you're lucky. That's a set point. It works the same way in addiction, and especially in opioid addiction. It causes permanent structural and chemical changes in your brain that once they get there, they want to stay there. Again, what that looks like at a biological level is this downregulation of receptors cannot always be fully reversed, all right? In some forms of addiction that it can, but with opioids, for whatever reason, it's much more difficult to reverse. So if we have a cell that downregulates receptors and then the person gets sober, that cell might be able to upregulate again to be in the middle, okay? But it never gets all the way back to where it started on the left. And what that means is that people are going to experience craving all the time for opiates. The second model is the cognitive deficits model. Opiate use degrades prefrontal cortical inhibition, all right? We're a little short on time, so I'm going to jump to the next slide. It's the same slide as before, but you cross out the prefrontal cortex, where all of your judgment and reasoning and restraint come from. The opioids cause damage there, and it can't do its job anymore, okay? And so really, addiction is a disease of the will. And we can think of it as a learning disability, like I said before with Pavlov's dog. This is a great slide because it conceptually illustrates all of the neuroanatomy here. And if you look at the left side, that little green ball that says drive, that's your drive to use, okay? That's a drive to use in a normal person who's not addicted. And you can see that the control, that's your prefrontal cortex there. It's nice and big and healthy. It's doing a great job of inhibiting the drive with a big red arrow, okay? The little red ball is saliency. That's how important drug use looks to you. It's not a saber-toothed tiger. It's not right there in front of you. It's not that important. And then down on the bottom is memory. There's some memory of pleasure, but it's not so powerful that it can overpower the control. But on the right, look at the control. It's shrunken and weak. It's damaged. The inhibitory arrow to the drive is small and dotted. The saliency is enormous. All you can think about is drugs. The memory reinforces the saliency, and the drive overpowers everything else, and you go out and you use, even if you've been sober for 10 years. Okay? That's why opioid dependence is so damaging. Take-home messages. Addiction is a learning disorder. It has biological, psychological, and social components. Historically, as I think you've heard today, biology has taken a bit of a back seat in terms of public policy as it relates to treating addiction, and opioid addiction in particular. The science of opioid addiction points to biology as a key component to managing the opioid crisis, and I hope that I've driven that point home today. Thank you very much. Yeah, you got it.
Okay, how was that for homegrown talent and expertise? Okay, I think we got time for one question from the audience. If anyone has a question from... Oh, Michael?
Thank you, Michael Carson with my house. Dr. Zelkis, you have some models on prevention model. Is that anything that you can address now, or is that something that you can address at a later date? Thank you.
Thanks for the question. You're welcome to email me through Senator Sullivan's office, and I can try to answer any question from anyone here. With regard to your question, that would fall under psychological sciences. Prevention's very, very important. I just didn't have time to incorporate it into my talk today.
We have one more question here.
Okay.
Hello. Hi. So when this conference first opened this morning, there was a lot of discussion about detox for opioid-dependent individuals, and we've heard some comments about residential programs. And, you know, CDC, SAMHSA, World Health Organization says that residential or abstinence-based treatment for opioid-dependent individuals works about 8% of the time. Detox has shown not to be any more effective than not doing anything at all. So I just want to know what role you think detox plays in treating the opioid epidemic in Alaska and in the nation overall.
There's a long answer to that, but I'll stick with the short one. There are lots of clinical reasons, and more importantly, there are lots of practical reasons why people need to detox before they can get into something else that is more meaningful as a treatment. But detox itself is not really treatment. It doesn't work to keep people sober over the long term. If you need to wait 6 months to get an appointment with the doctor who prescribes Suboxone or methadone, or to get into a residential program, you need to detox now, and then you have to wait. So there are lots of practical reasons and some clinical ones.
So are you going to be around the rest of the day, or you got to go home? For the breakout session?
Yeah, I'm not
Okay.
assigned to one.
Okay. So Dr. Sonkis is going to be here for the remainder of the summit, lunch, and this afternoon. So if you have additional questions for him, he will be here to answer those. So I think that was a really great presentation. Next, I'm going to turn, we're going to wrap up the morning session. And as I mentioned, I get to brag a little bit about, you know, veterans and others. I also done it a little bit already, but get to brag about my colleagues and my teammates in the congressional delegation in Washington. So what we're going to do first is hear a quick talk via video. Unfortunately, Congressman Young, who's also very focused on these issues, had a pre-existing conflict, a very important one, meeting with a group of wounded warriors. So we're going to hear from him very quickly via video, and then Senator Murkowski, who is also, as I mentioned, very focused on these issues, very focused on health issues, one of the leaders on so many of these matters in the Congress, is going to wrap up the morning session before lunch. So now we're going to hear from Congressman Young, I think. Good.
Don Young. I'm sorry I can't be at the Wellness Summit. First, I'd like to thank Senator Sullivan for putting this together, because this issue is one of the most important issues in the state of Alaska. I've covered the state the last month, and I've talked to many of the communities, and it always comes up. What are we going to do about the issue of drugs and drug usage across this nation, this state, and the nation as far as that goes, because it goes from Alaska to Florida. I want to thank all the speakers, everybody involved, because it is a collective issue. It's not one group, it's not anybody younger, it's not older, it's not ethnic groups. It affects the whole state of Alaska. I like the idea of you deal and you're done. The dealers are the ones making money out of this. We got to prosecute them to the fullest extent. I don't blame people that use drugs. I never have, because they're usually led into it. But I want the dealers that are making money out of it, mercenaries are making money out of it. They're killing our people in the state of Alaska. Well, maybe you ought to change the laws a little bit and make sure the person that deals may do better than just time. But you ought to look maybe at the capital crime problem again, to make sure that the dealer is punished fully to the fullest extent. One of the problems we have is the opioid drugs, prescription drugs, and those doctors that deal in that or those druggists that deal in it, that sell these drugs to individuals should be addressed every time. As a dealer of black heroin, which is the biggest problem we have in the state of Alaska, I know 1 in 5 American families has lost someone or knows someone has using opioids or in fact has used the drugs of their own kind. You have to understand this is an epidemic nationwide. So it's just not Alaska, and that's why I want to compliment Senator Sullivan for bringing this to Alaska. The idea of what do we do? How do we handle this? Do we have treatment centers? Do we have treatment centers, prevention centers? Those are the issues I believe we have to address as Alaskans, because I personally have lost 2 nephews now to types of drugs, quite a few years ago, factually the first one, and it is one that affects all our families. And I want us to take the responsibility and understand that we can maybe, I say maybe, because treatment is great, but I want to stop those that sell and make the money of it. That's what we have to keep working on. And Dan, keep up the job, and Senator Murkowski, I believe you're going to be there and doing so, bringing this point home, especially in the Wasilla area. I think it's important that we address the issue statewide. So enjoy your conference. I personally would like to have been there, but I'm traveling. As you know, this is a period of time during the year that I do travel. I'll be around the state somewhere shaking hands, and this issue has come up every time. So I'm trying to help you, and we'll continue to help you address this issue of drugs.
Okay. Our congressman, always a wallflower, right? Not very... Look, he's very passionate about this, and you can tell, and he's bringing up a good point. And as I mentioned earlier, you know, we're not focusing on law enforcement as much today. We have one breakout session, but we also can't be naive. I think that some of the people that are involved in bringing these drugs to Alaska or to the country are certainly not the good guys that we need to be coddling. So I next want to, it's my distinct honor to introduce somebody who needs zero introduction in the state of Alaska, who's very committed to this, Senator Lisa Murkowski, who is my partner on so many issues in the Senate, and it's just an honor that she's here today to wrap up, and she's been here all day, to wrap up the morning session and give her views on this important issue for Alaska. Please welcome Senator Murkowski.
Thank you. What a powerful morning. I think that kind of sums it up. And the power was really brought to us this morning by these 5 amazing women still sitting here in the front row: Kara, Teria, Christina, Kim, and Julie. What you laid in front of us, the comment that you made, Christine, that you have an opportunity to be vulnerable in front of total strangers, in front of a state, in front of a country, the opportunity to be vulnerable and speak to the power of addiction, and yet then speak to the power of hope. You are challenging us all, and I am extraordinarily grateful to you for speaking up, for urging all of us to be working on this horrible, horrible scourge that faces individuals, families, communities, our state, and our nation. Senator Sullivan, thank you for what you have done to convene this summit, to bring together those who are speaking of their own personal situation, those who are truly in the fight, those that are leading both at the community level, at the state level, and at the national level. This is how we come together to address the solutions. Now, I heard a little bit of criticism when this was first being discussed, this opportunity for a wellness summit. And what I heard was, we don't need to get together to talk about the problem. We already know we have a problem. So what are we going to do about it? What are the solutions? And I think we know where the solutions lie. I think we will all, each of us, leave this summit today with a list. Jeff Jesse had his list. And believe me, Jeff, I've got your list on my list now. And I think each one of us can walk away thinking, all right, there is something that I can do. And maybe it's being more vocal in my community. Maybe it is being more honest with the reality that we face. Maybe it is saying, I am vulnerable, but I am empowered to speak out to affect change. And that, in turn, allows others to have courage. I was in Nome yesterday, and I witnessed an act of courage from a 15-year-old young man that was incredible, who spoke to what drugs and addiction and substance abuse had done to him as a young man. How he had been influenced and how he had to use everything within him to stand up, to resist, to push back, and to be the strength for his best friend, to keep him from using. But he lost because his best friend took his own life. And that 15-year-old young man is standing up and saying, I'm going to do everything that I can, including speaking to a group of total strangers, including a United States senator, and saying, I'm going to be there so that nobody else feels so vulnerable that there is no more hope, that they need to numb their mind and their body to the extent that his friend had. 15 years old. If a 15-year-old can do it, if these women whose lives, and Dr. Wakefield, I think, expressed it beautifully, you can come 4,000 miles in an airplane to come and speak, but the journey that these women have taken is incredible, and it is powerful, and yet let it be an inspiration to each and every one of us. So let us use this as this galvanizing force to say, we can change, we can make that difference, we can offer that hope. And I think some of the things that we heard here this morning should allow us to move forward. I've been asked to do a little bit of wrap-up from the morning, and I want to give you some of my takeaways here. What Gloria O'Neill announced, what she, between CITC and Catherine Gottlieb at South Central, the teamwork, the partnering, where these two very strong women leading two very strong organizations coming together to say, we need to do more when it comes to our treatment facilities, and how we will partner together, not in isolation here saying, I'm going to deal with this constituency, this demographic, and you deal with that one. No, together we're partnering. We're going to make it happen. So the announcement today that South Central will take over the Ernie Turner Center, the announcement that CITC will focus in their areas on the outpatient services and the peer support and the assessments. This is strong. Now, Catherine stood before us, and she laid out the obvious. She says that her folks are saying, well, where's the money coming from, Catherine? We're going to go ahead and we'll take this on, but where's the money coming from? And she asked us all to invest. Invest of your time, invest of your advocacy. And we've got to invest the dollars. And so this is where I write in my notes in all caps, because as a member of the Appropriations Committee, and as the chairman of the Interior Appropriations Committee that has the oversight of the IHS, this invest puts a lot on my shoulders. And let me tell you, I'm squaring my shoulders, and I'm saying I'm going to personally commit to make sure that we have the investment that we need. If those of you can stand with your testimonials, your life, I can figure out a way that here in this state and here in this country, we can stand by those who are suffering with a level of addiction that they face right now. And it's not just within what we're doing with the IHS budget. It's within the VA as well. And I appreciate Drs. Lee and Drs. Drexel with the VA, because we know, we ask our men and women to serve, you put on that uniform, and sometimes you come back and the body's damaged. And even worse, the mind, the heart, the soul is damaged. And oftentimes, it's the easiest thing to do is to just write the script and move on, because our systems are overloaded. We can't get people moved through fast enough. We've got situations here in Alaska that we know are different. The statistics that Dr. Wakefield gave us about the impact of opioid use, abuse, addiction on our rural states is significant. We're living it. We know that in this state, rural doesn't mean the same as it does in rural upstate New York. We don't have the roads. We don't have the facilities. It is different, so we need to be allowed to have that flexibility to do things a little bit different. And whether you like the choice program or you don't like the choice program, the fact of the matter is in order to offer the services to our veterans, it's not just through the VA, because if you're out in Emonic, where I was 2 weeks ago, there's not a lot of VA out there. And so how are we helping those veterans who are suffering? Because those services aren't there. Well, we've got the ability to work with the IHS. We've got the ability to work through community health centers. We have structures, but we have impediments. We have barriers to access that are artificial, that are created by our own government. That's another thing that I've got to put on my shoulders, along with Senator Sullivan, to say, allow us the opportunity to craft this so that it helps those who are in need. It shouldn't make any difference whether you're getting your care from an outside provider, through the IHS, through a community health center. It's the care that we need to provide for you. So let's remove those barriers. Let's make sure that there are reimbursements that are available. When I was in Nome yesterday, I'm talking to traditional healers, those that are working with our natives, those that are working with those who are dealing with addiction. And they're telling me, you know, we're not recognized. We're not recognized for our treatment. Well, maybe in Bethel, maybe in Nome, maybe in Emonic, this is how we have to provide. This is how we should provide. This is the care that we need. So give us that flexibility. So we're going to be working on that end of it as well. So I want to end my comments. Congressman Young recognized that as he's moving around the state, he's hearing issues related to everything that we're talking about here in this theater this morning. I've been doing the traveling too. And I have to tell you, it breaks my heart. I was at the Chugiak Senior Center last week, and I'm talking to primarily senior Alaska women. There weren't too many men in the group. And we were talking about the issues that they care about. And I said, if I weren't here today, what would you be talking about at this lunch? And they said, oh, we'd be talking about our grandkids. And I said, well, like what? Like you want them to come back and live with their families here? One woman said, you know, my granddaughter called me up and she needed $600. And I wanted to help her, but I knew that she was just going to go buy drugs. Another woman said, well, there's so many of us now that are raising our grandkids because our kids are just so messed up on drugs. And then another woman said to me, you know, the only time I feel safe for my daughter is when I know that she's in jail. I mean, this is not what a grandma should be thinking about. And this is our Alaska. I was in Wrangell last week talking to a woman who's beside herself because there's no treatment there in Wrangell, and it's too expensive to come up to Anchorage, and there's no treatment up here anyway. And she looks down south, and one of the things she told me was that it's her daughter that she's trying to get services for. And she said, historically, there used to be more men that needed the treatment, and so the beds are there for the men. But we don't have the treatment beds for women? Okay, that's on my to-do list as well. I think we here in Alaska have a particularly unique struggle. And I don't mean to minimize or to suggest that we're so different up here, because we're not. Addiction attacks us the same way that Dr. Sankis outlined, this biological, this disease, this chronic relapsing brain disease, this learning disorder. That's going to impact a kid in a mnemonic the same way that it's going to impact a mother of 3 in New York. But our access to opportunities is what we've got to be working towards. But at the end of the day, we come back to the fact that there is hope. There is hope, and that hope begins in this room. Thank you for working with us as we work to address this horrible scourge. Thanks.
There you go.
I think they think it's stretch break.
No, that's good space. Okay, before the lunch break, Senator, we have time for one question for Senator Murkowski. Okay, way in the back there, is that hand up? The blue shirt? Yep.
Thanks for coming. It's been great. My name is Mike Alter. I'm an emergency physician at Mat-Su Regional. I'm on the Mat-Su Opiate Task Force here. I've heard a lot of great things today. What I'm going to say has already been said, but I'm going to say it again because I feel really strong about this. The opioid epidemic is like a flooded house. We can try and clean up the flood in the basement, but if you don't shut off the pipe, the problem's just going to keep coming. There is a big problem in this country with a pipe, and it's coming from the medical profession. For whatever reasons it developed through the pain scores, through satisfaction surveys, the problem has developed. If we don't stem the tide, the basement is going to continue to flood. The United States has about 3.5% of the world population. The United States uses 80% of the opioids. Life is not meant to be completely pain-free. There are certain conditions which necessitate opioids. Opioids are used in ridiculous quantities by the medical profession. This needs to be addressed, or you will never, ever, ever get the basement cleared of the water. You just have to stop these crazy satisfaction surveys, monitoring people for pain scores, people thinking they need Percocet for sore throats. They just don't. From the federal level, you need to educate medical students. You need to use the prescription drug databases to find out who these quacks are that are prescribing ridiculous amount of pain medications to 20-year-old people with chronic back pain. Give me a break. That's where the problem comes from.